All right, everyone, welcome back. Go ahead and settle in, get your water, get your notes, because today we are going to walk through one of the biggest foundational topics in nursing, oxygenation and circulation. This is going to be long, detailed, and honestly one of those lectures that ties together so much of what you'll see in clinical practice. I'm going to walk you through everything exactly like I would if I were standing in front of a classroom, explaining the concepts, filling in the gaps, giving you patient examples, and making sure you really understand why these things matter. And of course, we're going to move at a pace that makes sense for listening, not reading. So take a breath and let's get started. Section 1. What oxygenation really means. All right, let's start with the basics of oxygenation. And I don't just mean breathing. We're talking about the entire process of getting oxygen from the air into your cells where it can actually do its job. Oxygenation includes ventilation, perfusion, diffusion, and transport. And every piece has to be working or the whole system falls apart. So let's unpack these in a very down-to-earth, understandable way. Ventilation, air moving in and out. Ventilation is literally just breathing, the mechanical act of air coming in and going out. When you breathe in, your diaphragm contracts, your ribcage expands, and negative pressure pulls air down into the lungs. When you breathe out, the diaphragm relaxes and the air leaves. Pretty simple, right? But ventilation can get messed up by a lot of things. Think about asthma, the airways tighten. Think about pneumonia, the lungs fill with gunk. Think about obesity or pregnancy. The diaphragm can't move as freely. Even pain from abdominal surgery can make people take tiny, shallow breaths. So even something that sounds simple, just breathing, can get complicated really fast. Diffusion, gas exchange at the alveoli. Now let's talk about diffusion. This is the part where oxygen crosses from the air in your lungs into your bloodstream, and carbon dioxide crosses back into the lungs to be exhaled. If you think of the lungs like little balloons, the alveoli are covered in capillaries, and that's where the exchange happens. But this exchange only works if the alveoli are open, clean, and thin-walled. If alveoli collapse or fill with fluid or thicken, oxygen can't get into the blood properly. That's diffusion failure. Perfusion, blood flow reaching the lungs and tissues. Okay, so what about perfusion? This is the blood flow that carries oxygen through the body. You can have perfect ventilation, meaning you're breathing totally fine, but if blood flow is the problem, oxygen still won't reach the tissues. Perfusion drops in things like pulmonary embolism, shock, heart failure, anemia, dehydration. Perfusion is all about whether blood is actually getting to where it needs to go, transport, how oxygen travels to the cells. And finally, transport. This is mainly the job of hemoglobin, the protein in red blood cells that carries oxygen. You can breathe perfectly, and your lungs can function perfectly. But if your hemoglobin is low, the oxygen still won't get delivered. That's why people with anemia often feel short of breath, even though their lungs sound perfectly clear. Case example, normal lungs, abnormal oxygenation. Let me give you a scenario. You have a young woman who comes in complaining that she feels exhausted, dizzy, and short of breath when she climbs stairs. She has no cough, her lungs sound totally clear, and her oxygen saturation is fine. But her hemoglobin comes back as 6.8. Her problem isn't ventilation. It's not perfusion. It's not diffusion. It's transport. She literally doesn't have enough hemoglobin to move oxygen through her body. This is why understanding all four components is so important. Section 2. Understanding the respiratory system like a nurse. So let's talk about the respiratory system itself, the structures, and why they matter. When we talk about the upper airway, we mean the nose, the mouth, the pharynx, the larynx, the warm, moist, protective part of the system. This part filters air and protects the lower airway from debris. When we talk about the lower airway, we're referring to the trachea, bronchi, bronchioles, and alveoli, literally the business end of the respiratory system. This is where gas exchange happens. And then there's infants. Infants breathe differently. They have softer airways, larger tongues, and they're obligate nose breathers. That means any swelling can block their airway. This is why infants go downhill fast when they get sick. Section 3. The respiratory assessment. All right, let's walk through a respiratory assessment the way you're actually going to do it at a patient's bedside. First thing you do is look. You're watching the patient breathe. You're looking at the rate. Is it fast? Is it slow? Is it labored? Is the patient using accessory muscles? Are their nostrils flaring? Do you see retractions in the ribs? Then you look at their color. Pale, cyanotic, pink. Cyanosis, by the way, is a late sign of hypoxia. If they're turning blue, they've been hypoxic for a while. Then you look at positioning. If someone is sitting forward, leaning on the bed table, breathing with their shoulders, that's tripod position, a strong sign of respiratory distress. Then we move into auscultation, listening with your stethoscope. You listen for normal breath sounds first. Then you listen for the abnormal ones, wheezes, narrowed airways, crackles, fluid, raunchy, mucus, stridor, airway obstruction, a total emergency. Then you palpate for symmetry, tenderness, crepitus. Then you percuss. Dullness means fluid, hyperresonance means air trapping. This is the flow you use every day in practice. Section 4. Oxygen devices explained like a real nurse. Now let's talk about oxygen devices, because knowing which one to use and why is a huge part of nursing. We'll do this in a natural spoken way. Okay, if someone is a little low on oxygen, you start with a nasal cannula, 1 to 6 liters. Comfortable. They can eat, talk, drink. Easy. If someone's more hypoxic, you move to a simple mask. You need at least 6 liters so they don't rebreathe carbon dioxide. If they're really struggling and need high oxygen quickly, you go to a non-rebreather mask, the NRB. This thing can deliver nearly 100% oxygen, but the bag must stay inflated. If the patient has COPD, you avoid high oxygen because it can knock out their respiratory drive. You use a Venturi mask because it delivers precise, controlled oxygen. If the patient is in respiratory failure but not ready for intubation, you use CPAP, BiPAP, or high-flow nasal cannula. CPAP keeps the airway open, think sleep apnea. BiPAP helps with inhaling and exhaling, great for COPD exacerbations. High-flow nasal cannula delivers warm, humidified oxygen at high flow rates. Case example, COPD and oxygen mistake. A patient with COPD comes in with labored breathing and an O2 saturation of 88%. A brand new nurse puts them on a non-rebreather at 15 liters. Within minutes, the patient becomes drowsy. Why? Too much oxygen knocked out their respiratory drive. This is why we use a Venturi mask for COPD. Section 5. Upper airway disorders. Let's move into ENT disorders. These are the common but important conditions you'll see in urgent care, ER, and primary care. Rhinitis, just inflammation of the nasal mucosa. Could be allergies, could be viral, lots of sneezing and congestion. Sinusitis. When mucus gets trapped in the sinuses and bacteria grow. People come in complaining that their face hurts, their teeth hurt, there's pressure behind their eyes. Pharyngitis, sore throat. Could be viral, could be strep. If it's strep, we treat with antibiotics. Tonsillitis and adenoiditis. Kids get this a lot. Big swollen tonsils, trouble swallowing, maybe drooling if it's severe. Laryngitis. Your voice sounds terrible. Usually viral. Peritonsillar abscess. This one is dramatic. The patient sounds like they have a hot potato in their mouth. One tonsil bulges. The uvula shifts to the side. They have intense pain and difficulty swallowing. Epiglottitis. This one is the big emergency. A kid sits leaning forward, drooling, looking terrified, breathing hard. Do not shove a tongue depressor in there. You could obstruct their airway. Call rapid response and get ready for controlled intubation. Epistaxis, the nosebleed. Sit forward. Pinch the nose. Never tilt the head back. That just makes them swallow blood. Case example, epiglottitis real time. You walk into a room and there's a 4-year-old sitting upright, mouth open, drooling, not speaking. He looks panicked. You immediately stop what you're doing, back away, stay calm and call for help. This kid has epiglottitis until proven otherwise. Section 6. Aspiration. Aspiration is when something goes down the wrong pipe, food, liquid, or secretions entering the airway. Who's at risk? People who've had strokes, people with dementia, people who are sedated, infants, people on tube feedings, people eating too fast. Prevention is huge here. Sit them upright, give small bites, check their swallow, don't rush them. Section 7. Circulation begins. Now let's shift gears into circulation. If oxygenation is the supply chain of oxygen entering the body, circulation is the delivery system. It's how we get oxygen-rich blood to every cell. Let's talk about vital signs first. Section 8. Vital signs like a human explaining them. Okay, so we have the usual suspects. Temperature. Fever usually means inflammation or infection. Heart rate. Fast heart rate. Could be dehydration, pain, infection, stress. Slow heart rate. Could be meds, athletes, heart issues. Respiratory rate. Super important but often ignored. Fast breathing is one of the first signs of trouble. Blood pressure. If it's low, we worry about shock, bleeding, dehydration. If it's high, maybe pain, stress, fluid overload. Oxygen saturation gives us an idea of how well oxygen is binding to hemoglobin. Pain. Pain isn't just ouch. Pain changes everything. Heart rate, BP, breathing, perfusion. Section 9. The heart, structure and function explained like a teacher. The heart has 4 chambers. 2 atria on top, 2 ventricles on the bottom. The right side pumps blood to the lungs. The left side pumps blood to the entire body, so it's the bigger, stronger side. We listen for heart sounds. S1, lub, lines up with the closure of the mitral and tricuspid valves. S2, dub, when the aortic and pulmonic valves close. If you hear an S3, think heart failure. If you hear an S4, think stiff ventricle, often from hypertension. Section 10, the conduction system. The SA node is the natural pacemaker. It fires, the atria contract. Then it passes through the AV node, which slows the signal down a bit before sending it to the ventricles. Then it goes down into the bundle branches and Purkinje fibers, and the ventricles squeeze. If the SA node fails, the AV node takes over, but slower. If the AV node fails, the ventricles take over, very slow. This is why monitoring ECGs is so important. Section 11. Hemodynamics. Hemodynamics are basically the vital signs of the heart itself. Cardiac output, heart rate x stroke volume, how much blood the heart pumps per minute. Preload, how much the ventricles fill before contracting. Think of it like stretching a rubber band. The more stretch, the stronger the snap. Afterload, how hard the heart has to push to eject blood. High afterload equal to high blood pressure. MAP, mean arterial pressure, tells us if organs are getting blood. We want it at least 65. Case example, MAP of 58. A patient with a MAP of 58 is not perfusing their kidneys. Urine output will drop. This is a red flag. Section 12. ECG basics explained like you're sitting in lab. Normal sinus rhythm is exactly what we want. Regular rhythm, heart rate 60 to 100, P-wave before every QRS. Bradycardia is slow. Could be normal. Could be meds. Tachycardia is fast, usually from something stressing the body. We're not going too deep because your slides only covered basics, but these rhythms matter for circulation. Section 13. Anemia. Anemia means there aren't enough red blood cells or enough hemoglobin to carry oxygen. Iron deficiency. This is the most common. It causes fatigue, pallor, brittle nails, sometimes weird cravings like ice or dirt. Macrocytic anemia. This comes from B12 or folate deficiency. The red cells get big and clumsy. People can develop numbness and tingling if B12 is low. Case example, the ice chewer. A 19-year-old woman comes in saying she's been chewing ice non-stop and feels tired all the time. Her hemoglobin is low. This is classic iron deficiency anemia. All right, that was a lot. We've gone through ventilation, diffusion, perfusion, transport, the entire respiratory assessment, oxygen devices, upper airway emergencies, aspiration, vital signs, the heart, hemodynamics, ECG basics, and anemia. This concludes your full oxygenation and circulation spoken lecture.